All right, so we finished up last week talking about HIV. So what do we remember about treatment of HIV? What's our typical drug regimen usually? 3-drug regimen at the very minimum. 2 NRTIs plus something else. Okay, what's something else? Protease inhibitor is good, right? And usually protease inhibitors, some of them will be given with what drug?
The one that inhibits CYP?
Yeah, the one that inhibits CYP3A4, the ritonavir, usually will to boost it, right? So you'll do like a lot of like lopinavir, ritonavir. You'll do like darunavir, ritonavir. That's a common combination. What else could I use besides a protease inhibitor? Integrase inhibitors are another commonly recommended one. You could use an NNRTI as well, yeah. And nowadays, NNRTIs are kind of taking a little bit of a back seat because, again, when you can have mutations, it can confer resistance to the whole class. Yeah, so like raltegravir as the integrase inhibitor is starting to become more important from that regimen. But yeah, so again, the big thing to note here is that whatever I report on in this class can change drastically in years to come. So just look that stuff up, especially if you work with these patients with any regularity, you'll find that you're going to stay up on that anyway. So, but anyway, we at least get the basics down from our purposes. So let's continue on. So, other things that, especially patients who have HIV perhaps might have been exposed to as well are going to be things like sexually transmitted infections, or STIs or STDs. So as you may see out in the front lot there, I do drive a Subaru WRX, and it's like the STI version, right? And so, funny story, one time I was living in a condo for several years, and I was running around this neighborhood, and I see another guy with a STI in his driveway, and Subaru people are inclined to wave at one another and call each other out. And so I got my headphones in, I'm kind of running and listening to music, and I'm like, hey, I like your car. And the guy's like, thanks. And I was like, I have an STI. Not the thing you want to yell out at the neighborhood. Do not want to announce that. Yeah, so just be aware of your acronyms, and sometimes things mean different things.
How did he look at you when you said that?
He probably was not medically oriented, so he was like, yeah, he's thinking super, but. And yeah, thank goodness. Anyone else would have been like, ooh, just you stay over there on that side of the street. Don't come near me. Yeah, like my wife, when she got in the car, there's a little button for the center differential, but it's abbreviated C-diff. So she's like, oh, great, your car has C-diff from the get-go. I was like, oh, can't do much about that. Yeah, so my car is just an infectious disease nightmare. So I try to keep it so clean. Anyway, STIs. So we'll talk about the common ones. This won't cover everything, but these are ones you'll commonly see, especially if you're in the urgent care setting, especially if you're in the emergency department setting. These are things you're going to commonly want to treat. Now, the thing with STIs is, do we want to give these patients like really long courses of treatment? We typically want to do like one and done sort of things, right? Because again, if you're worried about compliance, if you're worried about them actually sticking with the regimens, this could be difficult, right? Because again, you don't want them to only go through partial treatment. Because again, if you say the treatment short, what can happen with those bugs? You need to get resistance, right? And again, sometimes these patients, and again, this is no value judgment on them or anything, but like sometimes the behaviors that led to them getting the STIs in the first place, they may continue to do those habits, and that could lead to being spread to other people, right? This is why treatment for the partner is so important, because a lot of these things a lot of people are co-infected. It's important they get treatment as well in a lot of cases. I'm not going to go super into depth on treatment for partners. However, there are law changes that have been happening recently where you can do things like, write for a script for their partner, and the pharmacy can fill that without ever actually having to see the patient, right? So there are some things where because of the public health risk of not treating is much higher than actually treating. That's why we're kind of moving towards that direction there. But anyway, so we're going to focus on usually trying to do one dose treatment. You can just give them the dose there in the ER or in the urgent care, and then they're done. And that's going to be very beneficial. If you can't get away with that, we'll see that we try to shoot for as short a time period of treatment as we can. So anyway, so gonorrhea, and have you guys covered any of these at all yet? Okay, so gonorrhea is going to be a very common one you're going to run into. It's a gram-negative diplococcus. So we're going to want to use antibiotics to cover for those gram-negatives. We're going to see that, typically, a lot of these patients, are they always going to manifest symptoms of disease? No, that can be a problem too, where again, they can be asymptomatic and then potentially spread it on to other people before they actually end up getting treatment for it. So that can be kind of difficult. But you may end up seeing, in some cases, guys may be more likely to be asymptomatic and can spread it. But here you're going to find that complications tend to be a little bit more pronounced in females for gonorrhea. Excuse me, and so you can have things like pelvic inflammatory disease, which can pop up here, which can lead to things like ectopic pregnancies, infertility. So again, definitely something you want to treat early rather than later. The other thing you're going to see is with a lot of these sexually transmitted diseases is that HIV spread tends to be easier in those patients as well. And again, I don't know the full mechanism for that. I don't know if something with like the biological, the bacterial environment tends to make it more easy to spread. It could also be related to, high risk behaviors as well. So those are other things to consider. But again, if you can get these treated, hopefully you drop down your patient's risk for spreading HIV, right? Because again, these are short course sort of things, but HIV lasts a lifetime, right? All right, so our treatment here, in most of the guidelines are going to come from the CDC, and this is another thing that you'll see kind of change as time goes on, because why would our recommendations for antibiotics change? Resistance, right? So again, you're going to find there's certain things that we'll recommend today that 10 years from now you wouldn't be caught dead doing because of resistance patterns. So for this one, we're going to be shooting for no pun intended, but shooting for IM Rocephin, right? So we're going to do a single dose of that, 250 milligrams intramuscular, and then remember that Rocephin tends to have a longer half-life. Ceftriaxone, Ceftriax 1, you only give it one time a day. Being in the intramuscular space, it'll kind of have a slower absorption than it would be if you gave it IV, and will have a stick around for a longer period of time. They really don't recommend a lot of other oral cephalosporins, mainly due to the fact you have to treat for longer. It may have a lack of efficacy. Ceftriaxone has retained efficacy for a good long time now, so this is our main recommendation here. The other thing you have to note is that when you treat for gonorrhea, you also need to treat for chlamydia, right? Because again, you can test for these things. However, are those results usually back immediately? No, they take time to come back. So again, oftentimes you're kind of treating empirically based on presenting symptoms and whatnot. So if you suspect gonorrhea, you should also be suspecting chlamydia at the same time. And for that, we're going to treat with usually a single dose of azithromycin. And again, azithromycin is what type of antibiotic? And it's a macrolide antibiotic. It's good for getting those kind of atypical sort of bugs, right? It's kind of one of the primary places we get some good coverage there. But you're going to get that as a 1 gram oral dose just one time, and then you're done, right? Because again, azithromycin has a good long half-life from that standpoint. The alternative you could do is potentially use doxycycline. You could do that twice a day for 7 days. I'm not going to get specifically into how many days you're going to use this drug, but again, these are kind of concepts to know. Like, you want to shoot for shorter courses when possible. Shoot for the one-time dose if you can. I'm not going to have the doses specifically for this test. Or if I put doses on there, I'm not trying to trick you with those doses. They'll be correct. But it might be like, which drug are you going to select based on your patient, right? Anyway, so who might doxycycline not be good for? Peds. So again, kids less than 8. Yeah, usually kids less than 8. Because why?
The teeth.
You see staining of the teeth. And who else might that not be good for?
Pregnant women?
Pregnant women. You don't want to give it to pregnant women because it can have issues with bone development and staining there for the fetus, right? So pregnant women, kids less than 8, typically do not want to give doxycycline. Most people are going to go with azithromycin if you can, because again, it's not super expensive, and you should give that one-time dose. Now, if they have a cephalosporin allergy, there's not really a lot of good alternatives. There's something like gemifloxacin, which is a type of fluoroquinolone we didn't really cover too much, but again, it kind of has the same sort of activities like levofloxacin or Cipro, things like that. Some patients would even do like intramuscular gentamicin, but again, the likelihood of someone having a true cephalosporin allergy is pretty low for the most part. Now, if someone says they have a penicillin allergy, can you give them a cephalosporin? Absolutely. So there is a very low cross-reactivity. So again, this has to be a true penicillin allergy, meaning they got a true anaphylactic allergy that less than 1% chance you actually can have a cross-reactivity there. It used to be reportedly higher, but that was based on how we actually produce those drugs. Because again, where did penicillin come from originally? Like mold, right? So again, mold produced as an antibiotic to allow the mold to kind of proliferate. That's how we used to have to make cephalosporins and penicillins. There's a lot of cross contamination of products. So if you had penicillin, there's a chance you could have had some cephalosporin mixed in there, and vice versa. That's why they thought there's such a high cross-reactivity. Nowadays, we have better means of producing that. That's not the case anymore. So again, if they have a true penicillin allergy, I would still feel comfortable giving them a Rocephin shot, because again, very unlikely to have any kind of cross-reactivity. Doesn't mean that's a 0% chance. It just means it's very low, right? You can do things like give like maybe a tenth of the dose IM to see how they respond to it. If they do fine, then you can give the rest of it. Some people do that if you want to be really conservative. But the nice thing about being in the ER is, guess what? you got all your stuff to treat anaphylaxis if you need to. Oftentimes I'll recommend that they will challenge the patient in the ER, give them a dose, see how they respond. If they're good in an hour or two, then they're fine, right? And again, this is just a one-time dose. It's not like something they're likely to have a reaction down the road from. So those are things just to consider. I had one kind of weird case. Did I tell you about that kid that had a reaction to clindamycin recently? We were working in, I was working in the hospital, and a nurse practitioner called up from the ER, and she had a kid, probably like 6 or 7, they wanted to treat for pneumonia. And so typically what our guidelines would say, or our kind of our treatment algorithms would say, is that use amoxicillin, usually use a high dose amoxicillin. Kid had a history on his allergy profile of penicillin, cephalosporin, but it was rash, right? And so I hear rash, like I don't really think that's significant of a reaction. Usually it's something where they're like, they don't even really know if that happened or not. It's just what the parents are reporting. So it's like, it's probably not a big deal. So the nurse practitioner is like, what can I use for this patient? So we'll give him a dose of amoxicillin here in the ER and see how he responds to it. She says, I don't really want to do that. It's usually the fight I have with a lot of providers. I feel very, because you don't want to be that person that causes the kid to have an anaphylaxis, right? You don't want to be that provider. But good safe practice, like you can try it in the ER, that's fine. So she didn't really feel comfortable doing that. So we said, well, the alternative in the guidelines says you can use clindamycin, right? Clindamycin will get that strep pneumo. That's the alternative, right? It doesn't get like any atypical bugs, it doesn't get any gram-negative stuff, but most likely the kid has strep pneumo. So what do you know? We give him a dose of clindamycin, guess what? Has an anaphylactic allergy. I don't know if I've ever seen anyone with clindamycin true anaphylaxis allergy before. So this kid probably has very sensitive immune system that's likely to respond, to react to lots of things. So he ended up getting admitted. So it's kind of unfortunate, but it's one of the things you just can't predict, and it's kind of a freak accident. That sort of stuff happens. But anywho. Yeah, as a backup there. I don't know what they actually ended up using. I was I'm only there one day a week, and so I kind of got like the follow up, like I got the text of the day after, and then saying, oh, that kid had anaphylaxis, and then he was discharged by the time I got back. So I actually don't know what they use. Probably a fluoroquinolone, if I had to guess. That would probably be the next thing you probably want to jump to. But again, and then when they're admitted, it's easy enough to treat anaphylaxis if you need to. You just want to have those, have Benadryl at the bedside, have Epi at the bedside ready to go just in case, because that kid is obviously going to need some allergy testing. Because if you're allergic to that many things, like you probably just need the full gamut worked up. Anyway, there are some cases where you can have eye infections with gonorrhea. In that case, we would actually use erythromycin. So, especially if a baby picked it up through the birth canal, if mom was infected at the time of birth, then that would be something we would cover for with erythromycin. So again, looking at chlamydia, again, the second most frequently reported STD behind gonorrhea. And again, usually a lot of underreporting happening here, because again, some people are asymptomatic. They may not actually ever get diagnosed in the first place. So it's probably even higher than this, maybe even twice higher than this. A very, very common infection here. Much more frequently asymptomatic than gonorrhea will be. So again, look at the previous slide for treatment. Doxycycline can be used. We can usually use azithromycin as a one-time dose. That's going to be most beneficial there. Now, they actually are starting to recommend not using fluoroquinolones in a lot of cases just due to resistance, because again, they got overused in a lot of cases. You see a lot more resistant strains popping up. So again, try to avoid those if you can. But avoid tetracyclines, maybe avoid fluoroquinolones in those pregnant patients. Just try to go to the Zithro if you can in that sort of case if they're pregnant there. And then again, for chlamydial infections in the eye, again, erythromycin ophthalmic ointment can be very useful here as well for them. For syphilis, so this is going to be a spirochete, so not really a normal type of bacteria we're used to dealing with, but Treponema pallidum is the infecting organism here. And so this one can be very highly contagious, especially in those kind of high-risk populations, like MSM stands for, anyone know? Sex with men, yeah. So it can be a pretty high-risk population there, and so the problem is that in and of itself it can be kind of bothersome to the patient, but you worry about the kind of the late-stage complications. So if anyone's ever seen a case like neurosyphilis, it can be very, very severe. It can be very, it can be potentially fatal. So that's why we want to make sure we're treating this early. And this one, even though you think like penicillin G, the drug's been around forever, like for whatever reason, syphilis has still retained good susceptibility to that. So you can still get away with using a shot of penicillin. Usually if we're going to be, again, we try to shoot for shorter course treatment. Is remember the long-acting form of penicillin we can use? That benzathine penicillin, that Bicillin LA, we used a lot for it's an IM shot. It looks like milk almost. It comes in kind of a lipid base. And again, it only can give IM, because again, if you give that kind of that lipid base into the intravascular space, it can cause an embolism. But That's a good one because there's a nice long half-life. That's why it has bicillin LA, so long-acting. You give a single-time dose of that. In cases where they've got more kind of systemic disease, you worry about things like neurosyphilis. That's where you can give like continuous infusions of IV penicillin G. That's going to be probably them up in the ICU for a long period of time, getting that kind of continuously. So again, penicillin, think syphilis, think gonorrhea, think ceftriaxone, think chlamydia, think azithromycin. So I make those kind of associations because you're going to be looking for drugs of choice and things like that for testing purposes, right? Okay, for genital herpes, so again, this is going to be more of a viral issue than anything else, and so we're going to find that certainly a lot of people end up being infected with this. A lot of people have this pop up every single year, and so we have two main varieties. We have HSV1 and then HSV2. Mainly, you're going to see HSV1's causing a lot of cold sores. See a lot of oral pharyngeal disease. HSV2 more with the genital disease. Does that mean that you can only have HSV1 in the mouth and vice versa? No, they can switch around, right? So there's nothing to say that they can't do that. It's just that's sort of the most common, where you can see the most commonly. And so again, a lot of high percentage of asymptomatic individuals. And the problem is there can be shedding a virus, and they can be spreading it to other people. So even if you don't have an actively occurring lesion, like you can still potentially spread it to someone else. So that's why it's really important that we try to identify those individuals, make sure they're being treated appropriately to kind of control the spread of herpes. So again, when they do have, and again, anyone know like if this is asymptomatic, is it kind of painful? Usually pretty painful, right? So these kind of herpetic lesions can be pretty problematic. And so we would like to shorten that clinical course if we can, try to reduce their symptoms there and try to prevent any recurrence or complications, and then hopefully decrease transmission, right? That's always going to be the goal here, is to try to prevent spread of these these STIs. And so as far as for the actual lesions themselves, you can do things like warm saline baths. We can do things like Tylenol, ibuprofen, antipyretics, things like that. The other big thing is just make sure to practice really good hygiene, because when you have those lesions, you can be more likely, especially if they're like scratching at them a lot or things like that, you can see a bacterial superinfection. So you want to kind of avoid that. So make sure you practice good hygiene, keep everything clean, practice good wound care, all of that until the lesion has kind of healed itself. So as far as the CDC recommendations go, they'll actually change the recommendations based on is it the first time they're actually having a lesion, is it a more recurrent disease. So for the first time episodes, usually they're going to be recommending either acyclovir, valacyclovir, or famciclovir. You guys remember what valacyclovir turns into? It's actually a prodrug. You take the val off, you just have acyclovir. Yeah, so that's actually a prodrug. That helps to increase the bioavailability. Because remember, prodrugs, are they active or inactive normally? They're inactive, they have to get turned into the active form by the liver. So valacyclovir or Valtrex, that one's given pretty commonly. And again, a lot of this decision on what to use is based on insurance coverage and what the patient can afford in a lot of cases. Because again, patients may not have a lot of money to spend on this stuff, and so the question is, what can they actually get a hold of reasonably based on their financial situation. Famciclovir can be used here as well, but I normally will either see acyclovir or valacyclovir most commonly. And the thing with viruses is, when do you want to start treatment? Early as possible, right? Things like common sense for any kind of bacterial infection or anything like that. But for here especially, the sooner you get it started, especially as soon as symptoms start up, the better efficacy you're going to get with this. So that goes for the flu, goes for herpes, goes for everything really viral related. So again, early treatment is better. If you can get it within the first 48 hours, you're going to see better efficacy than if you were to see after that. And so we'll see that, for all the first episode, patients really should receive treatment to help kind of prevent those lesions from sticking around for longer than they really need to. And then they have some topical varieties of things like acyclovir, but these are not going to be recommended for that. You think that might be good for just kind of getting good local concentrations, but it tends not to be super useful for our purposes here. Systemic therapy is going to be better recommended. Okay. And of course, what you can see is with immunocompromised patients, they're going to have a harder time fighting off those kind of flare-ups. And so them, or if they have really kind of severe disease, especially if they're having any kind of CNS manifestations, because herpes can cause things like, encephalitis and whatnot, they probably need to come in and get IV acyclovir as kind of the backup there. I've seen some cases where they have very severe cases in their ICU for weeks getting IV acyclovir for this. A lot more toxicity associated with that, so you have to worry about things like renal toxicity. You can see the acyclovir crystallize out in the tubules and cause acute kidney injury. You see bone marrow suppression, CNS toxicity, so it's not a very good drug. We don't like to use it if we don't have to. However, they're having those really severe infections, we need to go ahead and use that. And again, as immunocompromised patients may not be able to fight off the infection on their own. So, is there any cure for herpes? Nope. Yeah, all we have to do is basically treat these kind of recurrent episodes here. And so for the recurrent infections, there's kind of two ways you can kind of do this. So you can either give treatment based on as the episodes pop up, or you can kind of give it as a chronic suppressive therapy. So there's two varieties here the CDC might recommend. The episodic therapy is basically where you're initiating. If they have any kind of prodromal symptoms of a flare-up, you can start treatment within 6 to 12 hours after those pop up, right? So typically they will have a prescription for Valtrex or acyclovir they will have available to them. They can just go fill whenever they need it, right? Or they can fill it and have it available to start whenever they feel like they're having symptoms pop up. So again, good to educate them, make sure they're aware of like what to look for, when to start treatment, as soon as they can. But really no more than after 24 hours after those lesions show up. So again, earlier treatment's better here. This is going to be good for patients who have kind of like more severe sort of flare-ups, or if they have kind of prolonged occurrences. This helps to shorten that up quite a bit. However, the patient may still be able to shed virus, despite not having any lesions available, right? If they're shedding virus, that means they can do what? They can share the love, right? They can share it over to other individuals. So we don't want that to happen. Some people also recommend using chronic suppressive therapy, where basically they would be taking this how often? Every single day, right? So again, they're going to be on it kind of consistently. And they found that especially patients with really kind of recurrent or kind of frequent recurrent episodes, you can start to suppress these by about 70 or 80%, right? So again, it might be very beneficial for some patients. And they also find less asymptomatic viral shedding. And so the question is, that may sound beneficial. We don't actually know the full extent of it being able to prevent spread to partners and things like that. Or if you have like serodiscordant couples, where one person has HSV versus the other one does not. So again, there's probably going to be studies that will be done to kind of better illuminate kind of what those changes are. However, I think for a lot of people, they probably, and again, depending on the side effects and the financial situation, this might be better kind of overall in order to help kind of prevent that spread of disease. Because again, less virus shedding, we think logically less disease being spread there. Yes.
So it's no more than 24 hours after the lesion. Is it like pointless at that point? Or?
It's just going to be less effective. So I would probably still recommend they receive it, but we just know that it's going to be less effective, right? So it's one of those things where you give them the script with refills, right? So you'd say like take it for 5-7 days or something, PRN, HSV recurrence or something like that, right? I would probably recommend they go ahead and just fill it and hold on to it, rather than wait to go to the pharmacy once they start to see symptoms pop up, right? So that way they already have it available, it's at their house or something, versus having to go to the pharmacy, see if they can fill it. That just delays the time to treatment. Yeah. All right. Another one here, we have trichomoniasis. So this is Trichomonas vaginalis. It's a protozoal infection, so we need something that actually treats protozoas. And so this is going to be one of those things where, again, you're going to find that guys can still be infected with this, but guys tend to have a more higher spontaneous cure rate, tends to be more reported more commonly in female patients. Also, it's easier to spread from a man to a woman, so again, sorry ladies, it's just kind of how it is. However, we don't have a lot of options to treat protozoas, but we can use metronidazole or flagyl, so that's kind of another kind of a niche utilization for metronidazole. It does kill protozoas fairly effectively, so it's very good for that, so for trichomoniasis. Another one's called tinidazole, and so this one's going to be able to damage that protozoal DNA and cause toxicity there and prevent it from replicating. So basically, this is another one where we can give a single dose. It's going to be beneficial, so like just a 2-gram dose of either drug. That's the typical dose we give for that. And one of those things where if you treat the female who's symptomatic but the guy still has it, he can reinfect the female. It's one of those things where you can potentially treat the partner, and that leads to a better cure rate, right? So again, it's one of those things where you might give a prescription even though you've never seen the other patient, the partner, get a prescription for them, and then the pharmacist can fill it and provide that for them as well, right? So again, it's always going to be beneficial if you can get the partner fixed at the same time as you get the patient. All right, so any questions on kind of the more common STIs? It's a good way to start your Friday, right? All right, moving on, we have hepatitis. So what are the 3 main types of hepatitis we have? A, B, C. I guess I'm like you're in like an elementary school class or something. Let's go through our ABCs. Okay, yeah, so we have A, B, and C. Which ones do we have vaccines for? A, B. Yeah, A and B. C does not have a vaccine currently. Can we cure any of them?
C, right? This new pill.
C we can now cure, so that's actually one of the big changes here versus where we used to be. A will sometimes spontaneously resolve on its own. Sometimes the host immune system. We'll get into it in more detail, but yeah. So actually, let's just rather than me trying to quiz you guys on trying to read my mind. But anyway. All right, so hepatitis A tends to be kind of the less severe out of the group, so it kind of goes in kind of escalating severity with A, B, and C. Again, what's kind of the biggest risk with having hepatitis? Liver damage, and eventually what can you see? Hepatic cancer can also pop up here as well, right? So again, it's one of the big things we're trying to prevent. Usually with hepatitis A, rarely fatal, usually self-limiting. Usually the host immune system is able to go ahead and fight that off in a lot of cases. However, we're going to see there is some drug therapy, but we don't oftentimes have to utilize it for this. Now, a big reason why this has gone down in incidence is usually because we're now vaccinating for this more commonly. So a lot of people get their Hep A vaccines, and this is going to be one that actually spreads pretty commonly through fecal-oral route. How do like hepatitis B and C normally transmit? So it could be like sexual transmission, it could be like needle sharing, things like that. So again, those you see kind of the more typical spread like you would for HIV or something like that, especially hepatitis C. Hepatitis A though can just be spread through that fecal oral route, so it's a little bit different than you would see the other ones. In contaminated water, so this is something you can see a lot more like developing countries, or maybe they don't have as good like water systems and things like that, can be more likely to see hepatitis A pop up here. So as I mentioned, infection usually pretty acute, pretty self-limited, and if you get the infection once, now you're immunized against it from the future, right? So this would be one of those things where if you've never been vaccinated specifically for this, you could have protection if you've already had it one time. So usually what we're going to find is that nearly all individuals will resolve within 6 months or so. Majority of them can actually clear faster than that, so usually within 2 months or so. And basically, our goals here, we'd like to reduce the complications in the infection, including things like liver function, make sure that kind of starts to normalize out, and if we can prevent spread to other people as well, because again, that person will be shedding it into their feces, and that can be spread to others, and et cetera. So we have a hepatitis A vaccine. That's usually the best form of prevention that we have. So usually we'll see kids getting this at around 12 months or so. And again, you don't have to, I'm not going to make you memorize any kind of vaccination schedules, but just know there is a vaccine for hepatitis A versus C not having one. B definitely has one though. Here's some examples of ones. You're going to find there's lots of different brand names for different vaccines. I don't know that we'll have a section for this class specifically where we talk about vaccines, but just know there's lots of varieties that are out there. There's live attenuated, there's killed or inactivated. There's lots of different varieties. So you see different brand names. But anyone know where you find the most up-to-date vaccination guidelines? CDC, right? So again, for all things infectious disease, usually the CDC is a great starting point. Just go there, look up the most up-to-date vaccine schedules. Those come out yearly in January, and just make sure you're up to date with that for your patients. Other big thing, wash your hands. Seems like it should go without saying, but make sure patients are not being dirty and washing their hands. Make sure they're washing hands after changing diapers, food prep, all that good stuff, right? Now, for some patients, there is an immune globulin that's available, and what would that immune globulin do for us? Antibodies, they would just directly target that Hep A, right? They would just go straight after it and activate that. And so we don't use that very frequently because most people can kind of clear this on their own. However, it could be used for patients who are maybe at the extremes of age, maybe they don't really have a good immune system like infants or the elderly, or if they're immunocompromised. That may be one case where you want to give them immune globulin, but again, not super common. Now, hepatitis B tends to be very highly infectious, so actually more infectious than HIV. And so we can see that this chronic infection is kind of a big issue for causing things like cirrhosis and carcinoma in the liver. So again, this is one of those things where by preventing this, you can prevent potentially liver cancer. This is one of the first vaccines that was actually shown to reduce cancer rates because if you could prevent it, one less source to cause that. Anyone know any other vaccines that can prevent cancer? Yeah, Gardasil, the HPV vaccine, is another big one that prevents what type of cancer? Yeah, cervical cancer is a big one. Also can protect different anal cancers and things like that related to HPV. So but cervical cancer is the big one with that one. Anywho, this one can be spread sexually, parenterally, so again, IV drug abusers, they're sharing needles, things like that, and then perinatally, so mom could spread it to the baby potentially. And so again, patients, if they have persistent antigen levels, greater than 6 months or so, they are considered to have chronic hepatitis B, and they may not find that a cure is going to be possible. So again, some people may be able to clear this on their own. Some patients are going to have kind of chronic disease for this, and so you're going to see this more commonly in like perinatal infections. Okay. And again, it's going to be one of the first things you actually get a vaccine for. So as soon as you're born, then that first day or so, you actually end up getting the Hep B vaccine. So for both my babies, the first thing, nurse came in, got their first shot right there in the hospital, and then they're good for hepatitis B. So as I mentioned, preventing cancer. You're going to find that some patients you can manage with the vaccine, or there's actually a hepatitis B immune globulin. This is another case where we don't use the immune globulin very often. It's more expensive. There's other issues with that, but the vaccine is going to be the biggest thing. So some example ones include things like Recombavax, Energix B. This is one we use a lot for pediatric patients, Energix B. There's one called Twinrix, which is HPV and HAV. Right, so you kind of get dual therapy there. It's good for adults who maybe had never been previously vaccinated. I think if you go to work in a hospital, they're going to actually check you for titers, make sure hepatitis B is actually you have high titers for that. Otherwise, they may give you a booster, right? And what's the point of giving a booster for a vaccine? Yeah, it kind of reinvigorates the immune system a little bit to produce more antibodies against that, right? So for certain vaccines, you may have lifelong immunity, but for something like hepatitis B, you're going to find that it tends to dissipate over time. All right, because we're not actually infecting the patient with it. We're actually giving kind of a killed version of the vaccine or the virus, and so they can't really make a really good response to that will last a patient a lifetime. So sometimes we'll give them boosters to try to kind of boost up that response. They start to make more antibodies in response to hepatitis B. Right, so you may see that if you go to work in a hospital, they'll test you for titers for hepatitis B most likely, and then we'll get you boosted up if you need it. Anywho. So again, this is one of the cases where vaccine response is usually pretty low. So like they'll get like their first dose in the hospital and may get their second dose like at 2 months and then maybe like at 6 months in order to make sure they have a good kind of durable response to that initially and make sure they're protected for that time period, right? Okay, so again, our goal here, so say we have a patient with chronic hepatitis B, biggest thing we like to do is to maintain viral suppression, just like we would for HIV. And if they basically, we like to have the seroconversion to hepatitis B antigen, right? So it's just based on one of the surface antigens that the hepatitis B is producing. If we can seroconvert them to develop their own antibodies against hepatitis B, that's going to be beneficial. Or if we can have loss of the hepatitis B antigen, right? So if that was initially present, if we can measure that, if we can get rid of it, that's another sign of kind of good treatment there. And obviously, we want to prevent any kind of progression of hepatic complications here. So the question is, who should get treatment for kind of chronic HPV infections here? You're going to find that a lot of patients probably should undergo kind of serial monitoring. You're going to be monitoring hepatic function and kind of seeing how that's responding to that. Just because you have hepatitis B doesn't mean your liver all of a sudden just goes kaput. Usually it's going to take a little bit of time for that to occur there. So again, you're going to be monitoring initially, looking for things like levels of that hepatitis B antigen. You're going to be looking at their LFTs. And then basically you're going to be looking at your decision to treat, because again, you're going to find that the drugs for this are usually pretty toxic. Like we don't like a lot of the drugs we're going to use for this. So if we can hold off on treatment, it's going to be better for our patient. All right, so just an example algorithm you might see being used. So looking at, you have your threshold for treatment here. So you have the Hep B antigen is positive, and you have the DNA, say, greater than 20,000 units per ml. That would be something where you want to monitor the liver function. If it's less than 2 times the upper limit of normal, you may not do anything. You may just kind of continue to monitor that, make sure they're educated on how not to spread that to other individuals. And then if you do have some significant rise in like ALT, and greater than 2 times the upper limit of normal, that's where you can start to actually initiate therapy to try to get those viral levels back down, right? Because again, once these chronic infections develop, unlikely they're going to be able to clear, or less likely they're going to be able to clear it on their own versus if they could have done that earlier, right? Okay, so the drugs we can use here, have I ever talked about interferon before? I feel like I've mentioned it once before, maybe like cancer. Yeah, so interferon is a very nasty sort of drug, but basically what it's doing is kind of kicking your immune system into overdrive a little bit. So you're trying to stimulate your immune system, and so you can use that potentially to take out cancerous cells. You can use it to take out certain viruses and things like that. And so this is actually one of the first approved treatments for HPV that actually had proven long-term outcomes, positive outcomes here. And so basically it'll stimulate the immune system. You're going to find that it has anti-proliferative activities, so it'll help to kind of stave off the viral replication. It will kind of modulate that immune system to kind of better attack that. And so you're going to see a lot of side effects and potentially chronic issues related to this. We'll talk about those in a second here. Now, the other problem with this is it was a protein-based product, so it automatically makes it pretty expensive. There's risk for anaphylaxis associated with this, and you had to give yourself pretty frequent injections there. So 3 times a week, the patient has to inject themselves with this. Nowadays, we have a better version. It's called PEG interferon alpha. Pegasus is the brand name there, and so this actually has a longer duration of action. So this one you only have to give, let's say, once weekly. So you may see more people being kind of transitioned over to using PEG interferon rather than just the regular interferon alpha. So many adverse effects. This is a very nasty drug from a lot of standpoints. So one, you have risk for infection, especially if cirrhotic patients kind of decompensated, and this can actually cause some flare-ups in hepatic function here. So it could, if you had a cirrhotic patient, you can actually cause kind of fulminant hepatic injury for them potentially by giving this drug. So you got to be careful with that. A lot of black box warning for this drug as well. So things like neuropsychiatric issues. You see a lot of mood changes when patients are on interferon. They tend to get more aggressive, or their depression gets worse. So there's definitely something you have to monitor for. A patient may not really notice it themselves or be kind of aware of it. So you need to make sure their family members and whatnot are kind of monitoring for this sort of thing, because there is an increased risk for suicidality, things like that. So you have to be really careful with it. There's also other things like autoimmune conditions that can pop up from this. You can have ischemic issues, infectious disorders, so a ton of black box warnings, which is why we wait until we actually see the liver starting to take a hit before we start treatment with this, because it is very much a nasty drug. And again, we don't know the optimal duration of treatment, but maybe it's like 24 months. So again, 2 years is a long time for some of these patients, and this is a very expensive drug to be on as well, so this can be very problematic for some. Other drugs we can potentially use. Some of these we've already seen before. So remember we saw Ledipasvir being used for what? Yep, saw it for HIV. Remember what type of drug it was? Yeah, it's NRTI, so it's a nucleoside reverse transcriptase inhibitor. So this actually does have some activity against HBV. Not recommended first line typically, but you can find some patients when they get started on it, they'll remain on it kind of indefinitely. However, just like we saw with HIV, HBV can produce resistance. So again, resistance testing is something we'll try to do occasionally for those patients, and so you're more likely to see relapse of this as well. There's another one called ADVENTIST or Hepsera, which is going to be a similar mechanism. So it also acts kind of like an NRTI to lamivudine. And so this is good for if you develop resistance to lamivudine, you can actually use this as a backup. So you may see that being used occasionally. This one is more likely to cause nephrotoxicity, so you do want to monitor their serum creatinine and make sure they're not having any issues with that. Other agents you can use, one called Entecavir or Baraclude. This is also used for lamivudine-resistant strains, pretty similar efficacy to that, and safety issues there. And sometimes they'll actually consider this first-line treatment due to the fact that you have the safety issues that are not going to be really present like you would for something like interferon. And again, for a long time, the interferon is kind of what we had to treat these patients, and also kind of lower risk for resistance here. So Entecavir tend to be a pretty good drug. There's another one called Telbivudine. It's a little bit more effective than lamivudine, but a lot of resistance. And then tenofovir, which is another one we already saw used for HIV as well. Okay, so again, lots of different options that are here. We'll probably start off with like something like entecavir for most patients. And again, if they're still resistant, it's still not really kind of recouping, I might do something like an interferon, right? But of course, resistance testing is going to be really important for this to see kind of what kind of the virus is becoming resistant to. You may need to switch drugs as time goes on. All right, then hepatitis C. So this is the one that had really the biggest change in treatment, because now we actually can cause a virologic cure for these patients with hep C. So this is a huge, huge advancement for this. And so again, this was started back in 2013, and actually had a friend of my wife's actually developed hepatitis C. He didn't know about it for a good long time, but he was actually from a country in Asia. I don't remember, I think either Vietnam or somewhere like that. And actually, due to the medical care, something wasn't sterilized appropriately, actually developed hep C while he was over there as a child, and didn't really notice it until he was, well into his 20s. And so it's actually one of those cases where he was on interferon for a long time. He was on Ribavirin, which is another thing we'll talk about in a few minutes. But terrible side effects. So he was always a pain to be around whenever he was on that stuff, and it's because of the drugs. But now he actually has a cure. Like he's now cured of hepatitis C. So it's huge, very, very cool thing that we are now able to do for our patients. So anywho, so again, most acute cases end up going on to be chronic infections for this. So again, once you have it, you kind of have it for a good long time. At least that used to be how it was for a while there. The other big thing is that the host immune system really is oftentimes inadequate to actually deal with the infection, and you see a lot of viral diversification. Basically meaning what? Yeah, change of strain gets very resistant very quickly, right? So our goals of therapy here, so again, if we can eradicate the infection, we can do that now in a lot of cases. And so you'll be monitoring these patients for a while, so you want to make sure they have sustained virologic response, which means you want to have non-detectable hepatitis C virus RNA for at least 12 weeks after treatment. That's kind of our goal. So once you show that you've been 12 weeks after treatment and you have no viral RNA available, or at least detectable, that usually means you have a cure at that point. And then obviously the big thing here is to prevent kind of end-stage liver disease, cancer, things like that. Nowadays, we're going to recommend treatment for all patients, and so you want to do basically we'll talk about different strains of hepatitis C, but you got to do baseline testing initially to kind of see where they're at, and then that will determine whether or not they need to determine the drugs we can use. It will also determine the treatment, how long we need to do that, right? So we'll look at more of that in detail in a second here. Okay. So previously we used to have to use interferon therapy, and again that was fraught with a lot of side effects and whatnot, so we don't like that anymore. Nowadays we're going to use these oral regimens. Kind of the other big benefits. These newer drugs are actually oral options, and they're going to be using this for either 12 or 24 weeks. So keep that in mind. So again, 3 to 6 months. When we're looking at the cost of some of these drugs, so actually the cost is huge for these drugs. Yeah, and it's going to depend on the viral genotype. So typically you're going to have hepatitis C be listed as either GT1 through 6, and then you can have like a 1A and a 1B. These tend to be the most common subtypes in the U.S., but based on the genotype, it will dictate what sort of drugs you can use for it. So find some only have activity against certain strains. Some of them are going to be a little bit more kind of non-selective from that standpoint. So that's another thing you need to really test for. So essentially what we're finding is that when you're having, these are going to be called direct-acting antivirals, right? So if you remember how things like acyclovir worked, typically they were acting as kind of like a false nucleotide where they get incorporated into the DNA, kind of similar to the NRTIs. They get incorporated into the DNA, and then they would prevent further chain elongation, right? So that worked from like an RNA standpoint, a DNA standpoint. What we're now seeing is that when we're having some of these new drugs, they're actually directly inhibiting some of the proteins that the virus is using to produce new viral RNA. So if you can basically directly inhibit these proteins, you can't produce new RNA. Guess what? You can't produce new proteins. So this is a new kind of novel mechanism for some of these drugs, and we'll actually see with some of them, we're using combinations of drugs in order to act on different sites and act on different targets in order to kind of get better synergism with that. So the first one we have is and I'm sorry, these drugs are kind of a mouthful to say, so again, I'll probably just call them by their brand name in a lot of cases, but Ledipasvir. Again, they just, I guess they're running out of drug names or something, so they're just trying to make them as difficult to say as possible. But Declenza is the easier way to say that, and this is actually effective against HCV GT1 and GT3. I'm not going to have you guys memorize specifically which strains you're going to be targeting, but just remember that you need to do that testing beforehand. You need to make sure that they're going to, you can go off the assumption, you know, that 1A and 1B are most common strains. You can kind of treat for that, but you need to do that testing beforehand to make sure that they have, you can know what you're treating essentially. So anyway, so we have this Declenza here, and this is going to be working on this NS5A protein. So it was one of those proteins that was really necessary in order to produce new viral RNA. And so basically by inhibiting that, you kind of inhibit that RNA replication, and they can't do the virion assembly. Those proteins cannot be made effectively to do that. So basically what this does is actually distorts the structure of the protein and prevents it from working effectively to produce the RNA. The nice thing about these drugs, almost no adjustment for renal or hepatic function. So you could have a patient with full-on cirrhosis and you still don't have to adjust your dose, which is great. And the adverse effects, pretty mild for the most part. You don't have to worry about things like mood changes or cancers popping up from use of this like you do with interferon. The only downside of it is the cost here, right? So again, 3 months of treatment, $60,000, pretty expensive, right? However, how much does something like a liver transplant cost? A lot more than that, right? Or having to go to the ICU for a couple of days, you can rack up a bill like that pretty easily. So again, it's usually in the people at the insurance companies when they're looking at the balance sheets, it usually makes a lot more sense to go ahead and treat this now, get rid of that hepatitis C, than deal with all the consequences of that, right? So again, it's not uncommon for these drugs to be covered because again, with insurance companies, it's a lot cheaper to have a healthy patient than have a sick one on your, or a lot more expensive to have a sick patient than a healthy one, right?
Is this one of the new curative ones?
Yeah, so this is going to be a curative one. So all the ones we're talking about right now are going to be mostly curative. We'll talk about a few that are going to be more suppressive a little bit later, but I'll mark that delineation there. But yeah, so this is definitely one of the curative ones you can do. And I'll show you a table that will kind of show you the different regimens you'll use for this. This one is going to be a combination drug. So there's Ledipasvir and Sofosbuvir. Again, very difficult to say. So Harvoni is a lot easier to do. And so this will work against that GT1, 4, 5, and 6. This one has a little bit wider scope of activity there. And so you're going to find that the Ledipasvir is actually going to inhibit that NS5A and will block the viral replication. And then the Sofosbuvir is actually going to be working as a nucleotide prodrug. So it's going to be able to inhibit that NS5B. So it's actually working on a different protein directly affecting the RNA polymerase. And so basically this works a little bit more similar to the NRTIs, where it'll actually get incorporated as a chain terminator and prevent any further elongation on the viral RNA. So again, two mechanisms here. One's affecting the NS5A, the other one's kind of getting incorporated to the RNA and it won't prevent any further elongation. So again, you might imagine a little bit better synergism there as far as by using two different novel mechanisms to treat the virus here. Sometimes you can find the drug by itself, the Sofosbuvir, and so again, I don't usually put cost on a lot of stuff, but just because it's such a new kind of modality for treatment, it's good just to kind of illustrate the cost here. But again, no organ adjustment needed, no real side effects, to really note. But again, $30,000 a month. So again, pretty expensive, $90,000. I mean, you can buy a pretty nice car for $90,000, or you can have no Hep C. Right? I always like to equate like drug costs to like cars, so. We have some drugs. We have one. Anyone heard of SMA, or spinal muscular atrophy? It's a genetic condition. Usually causes kids to not have very good muscle control. They're not producing certain proteins. And very sad disease. But depending on the type, they may not live very long. Right? This is one of those things where they get kind of floppy, but they're not really able to protect their airway. It's very, very kind of a sad disease. But now we're starting to develop new treatments for that we actually were doing drug trials on at Nemours. And so we have one that's like I think it's like $250,000 per dose. It's like an intrathecal drug. I'm just like, holy cow.
Would insurance cover that?
It depends. Some of it is kind of more like compassionate sort of use. But again, this is a kid that would otherwise have a death sentence, so it's like one of those things where, I don't know. We'll do this kid whole. Now we have a new treatment for that as well. We're actually doing a clinical trial on where we're actually using a virus. It's actually an adenovirus we've modified to be injected intrathecally, and it will work as kind of a reverse transcriptase to incorporate the proteins that the patient does not produce. We're incorporating that DNA into their DNA now, so they can actually start the production of those proteins. And so I have a video of a little kid who is probably only a few months younger than my daughter. Still couldn't walk, couldn't do anything. Now he's like crawling around. It's like super cool. So like this is like medical science at its best from my standpoint. But anyway, besides that tangent, again, that would be another very expensive drug, I imagine, once that comes out. But anywho, so going forward, so we have Simeprevir or Olysio, and so this one's going to be working to inhibit this protease, this NS3-4A protease. And basically what this is going to do is that normally the enzyme is responsible for kind of chopping up the different kind of component pieces of RNA in order to produce new kind of functional proteins. So basically, if you can't do that, if you can't have that protease functioning appropriately, you can't form a lot of those HCV proteins. So you can't make the NS4A, the 5A, the 5B, all those things. So you kind of leave it as this kind of big, long chain of proteins that is going to be non-functional. So that can be another good way to inhibit the hepatitis C. This one's going to be a little bit more toxic, have some rash photosensitivity, but again, pretty well tolerated compared to some of the older ones. Again, still pretty expensive. Now, this is one you do not want to use by itself, so you may actually use it with something like Sofosbuvir, which you saw in the last slide, or in conjunction with interferon and Ribavirin. We'll talk about these two a little bit later on in its use, but we already covered interferon, and we know it's not a great drug. We have Ombitasvir, and so this is going to be an NS5A inhibitor, and so this is actually one that only comes in combination therapy. So you'll actually give this one in combination along with this Pariteprevir, which is going to be that NS3A4 inhibitor. So multiple mechanisms here, and then we'll actually give is Ritonavir as well. Remember, Ritonavir being used as a booster normally to help increase levels of other drugs. So this actually will boost drug levels of this Pariteprevir, and so this 3-drug combination is called Technivy. And then you can actually use a 4-drug regimen where you add this other one called Disapivir on top of that, and now you have this Vicura. Okay. Just know there's going to be different mechanisms or different drug regimens based on the type they have, based on resistance testing and whatnot. So again, they may get away with just having one drug regimen, or maybe be all the way up to like a 4-drug regimen, depending on kind of what's going on. Okay, another drug here is Ribavirin. So this is one we would, back before we had a lot of the newer direct-acting antivirals, we were using this in conjunction with interferon very frequently. So this one's more seen with like more suppressive therapy than actually curative therapy. We don't really know the full mechanism for how this one's working, but it tends to be immunostimulatory, kind of similar to interferon a little bit there. And it's also thought to lead to these kind of RNA mutations, kind of this error catastrophe where the virus gets so kind of mucked up with its RNA that it actually just triggers off apoptosis at a point there. But anyway, again, we frequently give it with interferon. Again, this one causes a lot of mood changes as well. So you see more suicidal ideation, more depression, insomnia. So again, these patients are just not fun to be around because they just had so bad mood alterations from the medications we were using on them. Another risk you see things like hemolytic anemia potentially, and it's going to be a pregnancy category X drugs. Again, very likely to cause birth defects and teratogenesis, and so they actually recommend that patients, female patients, be on 2 forms of birth control up to 6 months after discontinuation, because the drug will still stick around for a period of time. They want to make sure they don't have any kind of exposure to the fetus. Unfortunately, we don't have any kind of good washout kind of drug. Like, remember, like that teriflunomide, how that one will stick around for a good long time. We give cholestyramine to help increase elimination. This one doesn't really have anything like that. So again, if they want to get pregnant within the next 6 months, you're kind of out of luck, right? Because again, you don't want to cause the teratogenesis to the fetus. Okay, so as far as treatment tip goes, with Ribavirin, you're going to find this will be continued to be used mainly for difficult to treat patients. So say, for instance, they've been treated previously and they have resistant viral strains, or say they have underlying cirrhosis, you're more likely to see Ribavirin being used for that. Peginterferon has really gone down in use ever since the direct-acting antivirals have come about. So you don't really see as much interferon being used. Certainly for Hep B, still may see it used occasionally, but definitely not for Hep C anymore. Again, some difficult to treat patients still may need it. Now with cirrhosis, it can be very difficult to really get a good virologic response, get that good suppression. So typically what you end up doing is that you may have to adjust for the degree of cirrhosis. So mainly looking at, do I need to treat for a longer period of time, or maybe I need to adjust my dose somewhat. So again, I'm not going to ask you specifically to memorize which ones need to be adjusted for that. Just know that in some cases, especially with cirrhosis, you need to treat for longer, right? So when I say treatment experienced patients, what do you think that means? Yeah, they've been treated previously. So these would be like Hep C patients who've been on interferon before or Ribavirin before. Again, they're going to potentially require longer treatment, and they may actually need additional use of Ribavirin on top of those direct-acting antiviral agents. And then you can consider resistance testing for them as well. It can be another thing. Now for acute exposure, say you had like a really, like a needle stick exposure or something like that, about 50% of patients can spontaneously clear hepatitis C within, say, 6 months or so. So you can actually defer therapy until then, right? So you can actually defer giving it kind of treatment to see if they kind of clear it on their own. If not, then you can start treatment for them. Because now we have a curative agent, right? Before we didn't know that we could cure that. Maybe we'd actually want to start treatment early, like post-exposure prophylaxis or something, just to make sure they did not develop it, try to give them a fighting chance. But nowadays we can defer therapy. Now, compliance is super, super important here. So again, any delay can lead to resistance and failure. So you want to make sure they are being compliant as possible on this. And so you need to make sure they receive their medication every single month. So again, this is one of those things where you're going to be following up and make sure they get it for that 3 months or that 6 months that they're going to be taking it. Because again, you don't want to have any hiccups with the insurance stuff or anything like that. Because again, if you show up at the pharmacy and they're like, hey, by the way, it's going to be $30,000. I don't know if anyone has that kind of pocket money. If so, you probably wouldn't be here anyway, right? So, right, so again, it's one of those things you never want to show up and get a surprise like that. So again, it's good to make sure you have all the kind of the prior auths figured out and all that good stuff. If I had $30,000 in pocket change, I'd probably be like at a beach somewhere right now, or or driving a Lamborghini perhaps. I don't know. Anywho, so again, look, just and don't memorize this chart by any means, but again, just look at see how there's differences within the different genotypes of the virus. Look to see, there's differences between cirrhosis versus no cirrhosis. Typically, cirrhosis is going to require longer treatment, usually more drugs. So, for instance, with, say, no cirrhosis, you could use Ledipasvir plus Sofosbuvir for 12 weeks. You could use that Ledipasvir, Sofosbuvir. So, again, it's that Harvoni. If I can just use one drug, taking that once a day for 12 weeks, it sounds pretty easy to me, right? Versus having to inject myself multiple times a week, have those mood changes and all that. But typically, this is where you're going to add on Ribavirin is for the cirrhotic patients who have a harder time kind of getting that good viral suppression, right? So the earlier you can treat them, the better off they're going to be in clearing that as soon as you can. Kind of make sense? Well, at least what I want you guys to know from this. So again, get the concepts down, not necessarily memorizing the specifics. Because again, if you work with these patients, you'll get much more familiar with it. You'll kind of know it much better. But for our purposes, it's good to know the concepts. Yes, ma'am.
Before you leave that, so Ashley was asking about the suppressive rather than the curative. So is the Ombitasvir and the Ribavirin two suppressive?
Yeah, so if you can use a direct-acting antiviral plus Ribavirin or something like that, that can still be a curative therapy. But before, when it was just like interferon and Ribavirin, like those were just suppressive therapies. Like you couldn't still clear the HCV. You needed those direct-acting antivirals on board in order to actually get a cure. Yep. Any other questions? All right, let's do a break and we'll come back and finish out with our endo talk.